welcome to this month's perimenopause and menopause discussion. I'm Dr. Amy Loden Tiffany, Dr. Melanie McKean, and Dr. Becky Lynn and I meet once a week, and we talk about different things that we're seeing in our patients and really pick each other's brains. And we thought it'd be super fun if we invited everyone to listen. And more recently, we've started inviting some other colleagues to join us because menopause and the whole transition in this woman's period of life is such a big deal. And so many different people need to be able to help women. And we are delighted today that we have Brooke with us. And I'm not going to try to mispronounce your last name. So I'll let you introduce yourself in a minute. Um, she has done a marvelous job taking care of patients that I've referred to her over the last several years. And I know that that is the experience too of so many in both of your practices. So with that in mind, can I just, before we switch to Brooke, let Dr. McKean introduce herself and Dr. Lynn. And while each of them are talking, we're going to drop our socials in the chat so you could see those and take a look at them. And then we're going to start hopefully nicely interrogating Brooke and learning all the things that you ever wanted to know about physical therapy for the pelvic floor. Does that sound good? Awesome. All right. Dr. McKean, take it away.
Thank you. So, Dr. Melanie McKean, I am a reproductive psychiatrist. I've been practicing in this area for over a decade. I specialize in certainly bread and butter, pregnancy and postpartum, but I, over these past few years, have seen a huge boom in treating perimenopausal symptoms and mood and anxiety and helping my patients navigate that, and along the way have become really good colleagues with a lot of other people in the St. Louis area, which again is why we had started this. So I'm going to turn over to Dr. Lynn and we'll get going.
All right. So I'm Dr. Becky Lynn. I'm a gynecologist and I'm at Evora Health. And I specialize in menopause and perimenopause. So I'm Menopause Society certified practitioner, which means I had to do extra training, take a test, do continuing medical education, all that. So my practice is very menopause and perimenopause heavy. I also specialize in sexual problems in women, so low libido, painful sex, orgasm, arousal problems. And then I'm also board certified in obesity medicine. So we do a lot of weight loss here. We have a whole team of dietitians, trainers. We do medicines if people meet the criteria. And when it comes to menopause, as you can imagine, menopausal women have a whole long list of symptoms that we treat, and a lot of those are weight gain and sexual problems. So that really makes sense that they all go together. So yeah, that's me in a nutshell.
I love it. And so one of the reasons I love going after Dr. Lynn is she explains to you all the certifications we have, so I don't have to redo it. So like Dr. Lynn, I also am Menopause Society certified, obesity medicine. My original training was in internal medicine, and I really enjoy looking outside of the box. So I have some training in functional medicine as well. My heart's passion is to prevent heart disease and stroke in women. And part of that means looking at not just perimenopause, but postpartum health and looking at signs that these women are high risk for those problems later in life. And so our focus is on longevity, which who wants to be walking across Europe when they're 80 instead of in a wheelchair? If that's what you want, I'm your person. So thank you, Dr. Lynn, for saving me 20 minutes of trying to explain things when you did it much more beautifully. Good job. And now I'd like to turn it over to Brooke. Do you want to just tell our group here about yourself, what you're doing in your practice, what kind of you see on the horizon, and then we've got some questions that we hope we can pick your brain on.
Yeah, sure. So my name is Dr. Brooke Kalisiak, and it is a painful Polish last name, so I get it. Once you see it and you hear it, it makes sense, but until then, it gets butchered all sorts of different ways. But I own Legacy Physical Therapy, which is a pelvic physical therapy practice here in St. Louis, Missouri. We have 2 locations and 5 pelvic physical therapists, all here to help men and women with various pelvic issues. So we do see the gamut of the lifespan, but a lot of our patients happen to be in that perimenopausal and menopausal group because that tends to be a time frame where we start to see a lot of pelvic health issues. So that is a group that's near and dear to my heart, as I am firmly in the perimenopausal group right now myself and in the throes of it. So I really love helping to educate women on things they can do to optimize their pelvic health so that they're not having to deal with issues as they age, or if they are dealing with issues, to help them overcome them.
I love that. So well stated. And, you know, I think probably I've been referring to you for the past 5 or 6 years. Obviously, got a great practice that you've enveloped. But one of the things I love hearing about my patients when they come back is I didn't realize I had this option. I didn't realize that didn't have to suffer, right? Like the empowerment that you're giving women in this area is just, I think, beyond the value that they realize they're going to get. So one of the things I try to do when I'm sending someone to you is prep them. Okay, do you know what pelvic floor physical therapy is? Can we talk about that for 10 seconds? So if you had to describe this to someone who's never heard of it before, and their view of physical therapy is what they did for their back pain,
Yeah.
what would they expect in a first session from you?
Yeah, we definitely lead off, especially if someone's done any type of orthopedic therapy before, that this is going to be a little different. But there is some similarity. So we start out at the very beginning, just making sure that we're listening first. So we get a huge history of what's going on with their symptoms and what they're experiencing, what they've tried, what's worked, what hasn't, to kind of get the whole background of what's going on. And then we kind of jokingly break it up into the external and the internal exam. So external wise, we are looking at the whole body, because it does a disservice to just look at the pelvic area, and that everything's interconnected. So we are looking at posture, breathing, abdominal muscle function, how the hips are functioning, what the back's doing, how things are coordinating together. So that part of the examination might look fairly similar to what they've maybe done if they have done therapy in other places. And we're monitoring for symptoms, having the patient tell us what they're feeling as they're doing certain things. And then the part that's different from most therapy, when we incorporate the pelvic aspect of it, is that the gold standard for assessing the pelvic floor muscles is similar to a gynecological evaluation, in that we're inserting one gloved finger into the vaginal or anal canal to assess where these muscles are resting, how well they're contracting, relaxing, how well they're coordinating together. Are there any knots or trigger points or tender areas that are causing problems? And kind of getting a big picture of how these muscles are functioning with other muscles around the core. So the diaphragm, the abdominals, all those guys together. And so that part typically takes maybe about 5 minutes or so. It is always to patient's tolerance. So we have definitely had patients who are like, oh, I had no idea that was involved today, and I am not feeling prepared for that. and also had patients who are dealing with very severe pain complaints or trauma issues. And in that case, we meet them where they're at. That's the gold standard, but there's other ways to get some information, and we work towards that being a possibility in the future if that's one of the patient's goals. So
That's super valuable information. And I remember the first time I heard about physical therapy for the pelvic floor, and I was like, what? Like,
Yeah.
how is this happening? So I was quickly informed by my GYN colleagues what was happening. And since then, I've had so many people just really benefit. So appreciate that you're meeting women wherever they're at on the spectrum. We have a few different questions that we wanted to ask you, and I thought maybe we could popcorn those around if that's okay, because otherwise you get bored listening to me. One of the things before I turn it over to, how about Dr. McKean, you want to go next? I'll ask my question and you can ask the next one. Is that good?
Sure. That
Okay,
works.
perfect. So one of the things, and again, I'm coming from an internal medicine perspective where I send people for physical therapy for the rest of their body all the time. And we know that the muscles are connected and everything is one piece, as you mentioned. But one of my pet peeves with general physical therapy is it works when people are going, they stop doing the activities, it stops working, right? Logical.
Yeah.
So can you talk a little bit about, do you teach women to continue doing certain things at home to keep going on their own, or is it really more finite because you're in a different part of the body? How does that work?
Yeah, no, that's a great question. And yeah, I see that exactly what you describe happen all the time. And they're like, yeah, when I keep up with my back exercise, it feels great, but I kind of stopped doing them. It's like, oh, okay, well, I got a simple solution. Let's no. But no, we break it up into what we call the active phase of rehab and the maintenance phase. So if they're coming in, say they're coming in with a problem like bladder leakage, it's like, okay, we are actively working towards this goal of you being able to exercise without any type of leakage. And we set up a plan of care. Usually, typically, we're meeting with people once a week to kind of advance their program. We're teaching them habits and exercises and things that they can change at home, as well as things that we may be doing here at the clinic with them. And we are actively working towards achieving their goals of being leak free. And then as we're getting close to that in frame where they are leak-free with activity, usually about like a visit or two before the end of the plan of care, we'll usually say, okay, here's the deal. I want you to go do everything that you want to do that used to cause you problems. And I'm kind of setting you free for like a couple weeks now. Go do all that. And then report back. Where are we at? Like, are you leak free with it? Are you not? And kind of getting a sense of where they're at with it. And once someone has achieved their goals, that we use that last appointment to set up what we call their maintenance program. And for a lot of people, especially if it's a woman who is active in some type of fitness activity, because hopefully they are, because we want them to be, but if it's that they already have a fitness activity that they know, like, and trust, we incorporate their pelvic exercise into that fitness activity so that they can just keep up with it. They're already going to Pilates class. Let's just turn our brain on a little bit about what your pelvic floor is doing in that situation. Or you're already doing yoga. Let's focus on your pelvic floor a little bit with yoga. If it's someone who's like, I'm a couch potato and I do not plan to exercise, all right, cool, we can have another discussion, but we usually will have some minor exercises that they kind of keep up with and that. But as long as someone is already doing some type of fitness activity for the pelvic aspect, you can usually incorporate their maintenance program into their normal fitness activities so that they're already linking it to something that they like to do.
Oh, I love that because that's going to create habit integration too and the sustainability of that. Oh,
Mhm.
brilliant. Nice job. Okay, thank you. I'm going to turn it over to Dr. McKean.
Awesome. Well, again, thanks so much, Brooke, for joining us today. We've got lots of things that we would like to talk about. And one thing is I've been learning a lot more because a lot of people are like, why is a psychiatrist like getting involved with all of this perimenopausal stuff? And there can be the different mood fluctuations, but frankly, like there's so many folks that aren't that trained in it, even in the area of gynecology, that like any of us that can like complement and help women through it. And frankly, a lot of people are seeing me more often than they might be seeing some of their other types of clinicians. But so as I've been learning more about the different ways that I didn't even know, because I'm also in this phase of life too, that menopause could be affecting all my different organ systems. I've been hearing a lot about genitourinary syndrome of menopause, or like GSM, I think is the acronym for it. So I was wondering, this might be like a tag team of like you and Dr. Lynn both kind of like walking us through what exactly that is and how both a gynecologist and pelvic floor PT can collaborate on treatment with that.
Yeah. So, genitourinary syndrome of menopause. It's a mouthful, so I'm glad they shortened it to GSM, but it's really helpful. They used to describe it just as vaginal atrophy, which was a misnomer because it misses out on all of the effects around the pelvic area. So genitourinary definitely is more helpful, but it just is a way to describe the changes that can happen to the tissues with the menopausal changes because of the lack of estrogen in the area. And it describes some of the problems that women can start to have. So some of the most common, and Dr. Lynn can fill us in on more, but like recurrent urinary tract infections, bladder leakage issues, pelvic organ prolapse, pain with sex, low libido, you name it, anything that can kind of go wrong in that area can start to go wrong when we take estrogen away from it and that. So did I miss any big ones, Dr. Lynn?
I think that pretty much covers it. It's basically what happens to the genitourinary syndrome when there's a lack or a decrease in estrogen. And so when there's lots of estrogen around, the tissue is thick, it's moist, it's got a lot of blood flowing to it, it stretches, it has collagen and elastin. I know you guys have heard me say this umpteen times in the past on other one of these YouTubes. But when you lose that estrogen, the tissue gets thin and dry, which vaginal dryness due to menopause. It used to be called vaginal atrophy. It is kind of the tissue's atrophic. Can cause painful sex. And then there's less blood flowing to it. It's more prone to irritants. If, you're using something or you're wearing pads because you leak, you're more prone to irritation. There's a lot of effects on the urinary tract. When you lose that estrogen, the tissue that supports the urethra isn't quite as strong. So people are more likely to have leakage or prolapse. People are more likely to have bladder infections. So just like a little clinical pearl, if someone who's postmenopausal keeps getting bladder infections and they keep getting, antibiotic after antibiotic, and then you get resistance, and then your gut microbiome is not your friend anymore. Like, the treatment is so easy with some low dose vaginal estrogen. So basically it's just the changes that happen to the vagina and the urinary system, the lower urinary tract, pretty much, when you lose your estrogen at menopause.
I was so happy to see the AUA come out with the guidelines for
Finally.
GSM. Finally, yeah, and that a lot of us have already known. And it's like I'm frequently here as a pelvic physical therapist, I cannot prescribe medications, but we often have patients asking, and we often talk to patients about vaginal estrogen and telling them that this is something that you should go to your internist, your gynecologist, that have that conversation with them to see, because we think that could potentially be really, really helpful for you, because in so many of the menopausal women, it can be a game changer for them. So,
and the one thing to say about that is that it is exceedingly safe. So vaginal estrogen does not increase your risk for blood clot, heart attack, stroke, breast cancer, nothing. So pretty much everyone can use a low dose vaginal estrogen. The benefits are huge and the risks are exceedingly small.
and we need like 100 million more of us screaming that from the rooftops to get rid of the old bad information that's out there and be like, nope.
Zombie idea. The idea that vaginal estrogen is dangerous is a zombie idea because it just won't die.
Yeah, that is true. Very true.
Brooke, are you finding that as you're maybe a patient's coming to you for a different reason, but as you're examining them, that you're the one educating patients about this, or are they coming to you being referred by gyns, or is it a mix?
It's a mix, but a lot of times we might be the first person who is identifying changes in the tissue, because they come to us because they started leaking with exercise, or they started having some urgency issues, and they're like, oh, my friend said I should try pelvic physical therapy, or, I heard about it on social media, so like I'm trying pelvic physical therapy. So we might be the first one to identify, and then like referring back to their physician to be like, cool, we definitely want to work on any structural issues or problems that are occurring with the muscles themselves and help on that respect, but your tissues are also going through these changes, and so it may be helpful to look into the use of vaginal estrogen or some other treatments to help along that line. So it's a mix, probably about 50-50, where sometimes it's providers who are referring people directly our direction, and then other times we might be referring the other way to help people kind of get the best of both worlds in their care.
And people can start self-referring now for physical therapy, right? Wasn't that kind of a change between the way it used to be that you always had to be referred by a clinician?
Yeah. So Missouri finally caught up with a lot of the rest of the states. And so we do have direct access in Missouri. Missouri also has to, continue to be Missouri and be the show me state. And then so we can see a patient without any type of referral for the evaluation report appointment. And then we can see them for 10 visits or 30 days, whichever one comes first, without, before we have to notify one of their providers. So we have to make contact. So we don't need a prescription for physical therapy anymore, but if we've got someone who is straight up self-referring, does not have any doctors whatsoever, anything like that are part of their medical care team, we have 30 days that we can work with them before we technically by state law have to notify someone that we're working with on that. So, and hopefully in that time, if they don't have a provider, like we're helping to connect them up with a provider, and that. So that's kind of a not as common a situation. Most of the time it's like, hey, let me, call up your gynecologist's office and let her know that, we're working with you and we're making progress, and we're going to continue working past the 30 days and that. So we sometimes ask people if they do have a prescription for therapy, because a lot of times providers do write them. And if they do, that kind of overrides the law, especially if the prescriptions just says like physical therapy, evaluate and treat for bladder leakage. That's good for a year from the time it was dated. And so that means that if we have that in place, we don't have to be notifying the doctor's office every 30 days that we are continuing to treat the person. So if someone has that, we like that because it's kind of
huge step forward from the way it was.
That like makes it a little bit less cumbersome of like keeping track of stuff. So
yeah. in general, how long, if somebody was like, how long will it take me to notice some improvement from pelvic floor PT? What kind of guidance do you give people at that, maybe that initial evaluation or the first treatment visit?
Yeah, no, that's a great question. Honestly, we like to see some type of improvement within the first couple weeks. Now, if someone's been dealing with something really chronically, and we'll be very honest with them up front that we may be working together for several months to try and get this moving in the right direction. But the body is super malleable and can make changes, and we can make effect on it. And so in order to, keep people kind of motivated and moving in the right direction, we should be seeing incremental changes every couple of weeks. And I tell people to kind of look out for that and let us know, like, if you're not experiencing changes, then we maybe missed something on the evaluation and we need to reevaluate, or maybe we need to get someone else in on the team to make sure we're addressing all aspects of it. So that's how we kind of prep our patients here with it on what they should expect.
Gotcha. All right, Dr. Lynn, I'm going to volley over to you for some questions.
Sure. So I would say in my practice, I'm so grateful that you all exist, Brooke, because you help so much in so many things that menopausal women deal with, namely leakage, prolapse. But I also see, because I do sexual dysfunction, I also see vaginismus or pelvic floor muscle spasm. And sometimes I see this in menopausal women who have atrophy that leads to painful sex, and then their response is to tighten the pelvic floor, which makes sex even more painful. So what are the steps that you do, or how do you approach that?
Yeah, so no, that's a great question. And that kind of goes to like people's pain response. That's a common pain response is to have muscle tension in and around the area. And that becomes a vicious cycle where, okay, something hurt. And so my muscles tensed up around it. And they've actually done studies. We couldn't get these studies passed now, but they used to do studies where they put little needles in the pelvic floor muscles, and they showed women like scary movies or like funny movies, and like the women's pelvic floor would actually clamp up and tense up when the scary movie was on, and it would be fine when the funny movie was on. Again, not a study that could ever be done now, but the pelvic floor muscles, especially the superficial ones, can be protective in nature. And so even the thought like of that this might be painful, women can end up in that kind of clamped shut or tensed position. And so we work a lot with that to help women kind of desensitize and down train the muscles. So pretty much like the opposite of a Kegel exercise. So a Kegel exercise is a contraction of the pelvic floor, and the pelvic floor muscles should be able to contract, but I equate it a lot to like, if it's my shoulders, I don't want to walk around all day with my shoulders in my ears. Like, they need to relax and come down. And if my pelvic floor is that tense all the time, when it needs to stretch for, penile penetration or any other type of penetration, it's not going to be able to do that if the muscles can't relax. And so there's various ways that we can work with people to try and help with that. Some of it can involve manual, like hands-on tissue work, where we're just trying to stretch and get the tissues to release to tolerance. All of it is not forcing through pain, because if you try and force through pain, it becomes even more painful, and we just keep that cycle going. A lot of times we're working with people on progressing them through vaginal dilators, which are progressively starting very small. From some of them are smaller than like a finger, up to partner's penis size, or your toy vibrator that you really enjoy size. Working on progressively tolerating that stretch to tissue and increasing that slowly over time. We do that. Yeah, I know we're talking about menopausal women here, but we do that a lot with our postpartum mom population, because they get the green light at 6 weeks, go back to having sex, and they're like, whoa, but I had an episiotomy and I had the scar tissue and my partner's kind of large. And so to jump from like scar tissue that hasn't moved at all for 6 weeks to a large partner isn't a fun jump. And so a lot of times we're working with them on like, okay, let's gradually increase in size with the dilators. And, we can even use what's called biofeedback, which helps to show people in a visual or an auditory way what their muscles are doing. Because sometimes people are extremely surprised. They're like, I thought my muscles were relaxed. and the line's bouncing off the top of the screen because everything's tensed up. They're like, I don't even feel that. And it's like, yeah, that's why sometimes it's helpful to have a visual or an auditory cue with it, because this is an area of the body that oftentimes, unless we have a problem in that area, and even sometimes when we do have a problem in that area, we're not super aware of how it feels and what's going on. So a lot of times it's kind of cueing people in to what's going on with the muscles and cueing them in different ways that they can work to relax them and get them to move more.
Yeah. I love that shoulder analogy. I'm
I use that
so
one all the
glad
time.
because that's so true. Just kind of nails it. So what do you tell or how do you approach it when patients are nervous or they think it's weird that there's, someone's going to do something to the vagina? Like, how do you sort of allay their fears or, let them know how things are going to proceed?
So a lot of patient education up front. We have models of the pelvis in our office, so we'd get that out and show them where the muscles are, show them diagrams of how they work together and why their muscles can potentially be causing issues. Giving them a lot of analogies to other areas of the body. Coming back to the shoulders, it's like, how you can get that knot up here in the shoulder, and you just want your partner to kind of like dig into that knot and to free it up. Like, those knots can happen anywhere in our body, including in your pelvic floor. And so we might find some tender spots there, and that can be potentially contributing to your pain. So trying to bring it into examples that they might be more familiar with. And then, explaining that, one, they are in complete control the entire time. We will, like several of our patients kind of like laugh at us because, not laugh at us, but laugh with us because they're like, you don't need to keep asking permission. I was like, oh, yes, I do. Like, I'm going to ask permission many, many times throughout this examination because you are in control of this and we don't force through pain. And so giving women that autonomy and that kind of like that feeling like I am in control of it is huge to help them feel more comfortable with it. And, I'm not going to lie, we have had evaluation appointments where the person has sat in the chair comfortably talking to me and I've been chatting with them. And that has been our evaluation appointment because that was where their comfort level was at. That's where we started from that day. And that's fine. That's where we start from. And we just know we have a longer road to go down. And I lay that out to them. And, I've had patients, we've all of us here at Legacy have had patients where it's maybe been 4 or 5 visits, maybe even 6 visits in before they're comfortable letting us touch in that private area. And that's okay. We meet them where they are and move them forward.
Yeah, so that's interesting about the control. I was thinking when you were talking about that, how, when I see patients who have vaginismus or pelvic floor muscle spasm, I send them your way. And when they come back and they're ready to try intercourse, I always say, you need to be the one to guide the penis in because you need to be in control. Because otherwise, you do all this lovely work at Legacy Physical Therapy and you're like, okay, we're going to try it. And you're like, okay, go. And you can't help but tense up because you have no control. And so I love that you said that about the control. And that's, definitely what I tell my patients, you guide the penis in because you can stop it if it's too much.
Yeah, and we oftentimes, like, especially if someone is getting towards the end of their plan of care and they're doing well with their dilators or that, and they're worried about that transition back to sex, like, we'll work with the dilators if their partner's willing with the partner, and where it's like, okay, I want you to be inserting the dilator and I want you to feel comfortable with having your partner's hand over yours while you insert.
Wow.
And if that's comfortable, then let's switch. Your partner's holding on to the dilator and you're on top of his hand or their hand and seeing if you can let go of that level of control. Okay, if that's fine, now you take your hand away and you're verbally telling your partner what to do, like, and seeing how they respond to it with the dilators. Because sometimes that transition, they're like, I'm doing great with the dilators on my own, but that transition back to sex can be really challenging. And oftentimes that's when we start to bring up here, bringing in another team member and having a sexual therapist, join the conversation. I know guys interviewed with Angela Skirtu and that, like, bringing someone like that into the conversation to be like, okay, like, now that pain's not the issue, I still don't know how to do this. Like, I don't know how it's going to be comfortable. So let's bring someone else in to help on that aspect of it. So
Well, I would presume there's a lot of like muscle memory that is similar sort of like in other aspects of things, because yes, even if they've had the treatment and they've been doing it, yeah, as soon as their headspace gets back into, trauma, certainly you had mentioned that earlier too, like even if everything seems very safe and it's a much different environment, right, it can just send them right back. So I think I love hearing that about like bringing them, I do that in a different way as far as like bringing partners in to get ready for postpartum. But I love that, like bringing them in and having them do that like stepwise sort of thing. Because again, also in like what I do, it's nice for them to like have met the clinician and really see like the work that's been being done and those recommendations, and for them to know like, people don't really understand. You bring out those models. I've seen your models, like it's just amazing how many muscles are down there and in like a very like small space, and how they can interact with each other. And so I think a lot of people just getting that education and realizing that like this is an area that's often ignored and it's really important that it gets that kind of attention and that care.
Yeah. And I love sort of the team effort. Like there's a physiologic aspect. So maybe they need low dose vaginal estrogen if they're menopausal. Then there's the muscular aspect with physical therapy. And then there's the in your mind aspect. So it really is a team effort. And I think especially when there's pain, that's really important. So
very much so.
yeah. Was there we talked a little bit about prolapse, leakage, pelvic floor muscle spasm. Was there anything else that I missed that you can think of that's typical for menopausal women to struggle with their pelvic floor?
A common one that we see is the woman who has, I'm going to put in air quotes, has recurrent UTIs. So yes, when menopausal women are more at risk for UTIs, and they can have recurrent UTIs.
Yeah.
But we get a whole class of patients here, like I can just picture them. I know their story with it, and they're like, yeah, I keep getting these UTIs, but I get it tested and it's not an infection, but it feels the same. Like I know I have an infection. And I was like, okay, so I have to take them down the road of like, okay, everything, a mentor of mine a long time ago told me, she's like, everything in the pelvic area is very gossipy. Everything talks to everything else. All the nerves are interconnected down there. So the bowels are talking to the bladder, talking to the uterus, talking to the pelvic floor, and they all gossip to each other. So when the bladder gets pissed off the first time that you have a urinary tract infection, it affects the nerves around the area. And you can kind of, like Dr. McKean was saying, you can get that muscle memory, and the muscles might be a little irritated and uncomfortable. The nerves are a little irritated. And they kind of remember that. And it can kind of pop back up even without the infection being there. And so these women think they have an infection, but if they actually do the full-on test, they don't. But if we get them in here and we evaluate their muscles, they're like, oh yeah, your pelvic floor muscles are doing the shoulders in the ear thing. And that is what's irritating the nerves and causing the issue, causing you to feel that urgency, frequency, burny situation. And so we actually need to calm that down to get over it versus you going on antibiotic after antibiotic for an infection that's not there.
Yep. So that's really interesting to hear you say that they gossip, because one thing that I've learned, which I didn't know until I became involved with endometriosis and pelvic pain, I didn't learn this in residency, was that the nerves that travel from the bladder and from the bowel are next to each other up the spinal cord. So when one gets irritated, the other one gets irritated. And so people with painful bladder syndrome or interstitial cystitis are more likely to have irritable bowel syndrome.
Yep.
And so I've just never heard it described as gossip, but I'm going to have to adopt that one too, because that makes total sense.
Yeah, love that.
Yep.
Very cool.
So for women who have never or see you and are kind of graduating out, and or just women in general, do you recommend like a certain frequency of having a pelvic checkup? Like, I've gotten to a point as far as like my postpartum moms, like recommending that all of them go for an evaluation, even if like they didn't have any sort of tear or episiotomy. I'm like, it's worth it to go like get it checked out. So I know we're still in the process of trying to get that to be part of like the postpartum protocol. But just in general, how often do you or what would you recommend to somebody on when they should see a pelvic floor PT?
Yeah, no, that's a great question. Honestly, like I think of it like going for your annual gynecological appointment or going for your twice yearly dental appointment. Like I think once a year check-in with a pelvic PT would be an amazing thing if we could get that to kind of, be the standard. Right now, I think more realistically, yes, having someone check in at like the 6-week mark after they've had a baby, and like you've said, I've had many people who we green light them. They're doing great with stuff, and we tell them about things that they might want to watch out for or avoid or things that might warrant them coming back. And a lot of people were catching things early before they're developing issues if they come in at that point and we're able to stop issues from happening. Because what a lot of women don't realize is that the body is awesome at compensating for a long, long time. we can do a lot of damage to our body, and our body will put up with it for a while. And where a lot of women who have issues that start during their childbearing age, that they don't necessarily have any symptoms of them, they start to get the symptoms in menopause. And they're like, it just started. I was like, oh no, this started 20 plus years ago when you had your baby and you didn't rehab your core and your pelvic floor, and you've been holding your breath and straining and pushing to pee for 20 years, and now your pelvic area hates you. So it typically kind of starts before that. So I think for sure, when someone is pregnant and then when they have the baby is a great time. When you have a significant change to your medical history, so maybe like I had gallbladder surgery last year, and like some people this might sound weird to people, but I had my therapist working on me afterwards, working on the scars in my abdomen, making sure my core muscles and my pelvic floor and all that weren't affected from that abdominal surgery. So anytime you have like a major abdominal surgery or pelvic surgery, you should be seeing a pelvic physical therapist. And then when you know that you are starting to go through the change. So in those perimenopausal and menopausal years, that might be a great time to go yearly to track the changes that are happening in the pelvic floor, and to make sure that you know what you need to be doing to kind of minimize or eliminate symptoms that you might already be dealing with, or to prevent symptoms that you from ever developing. So.
Yeah.
And I would think the fact that they don't need that referral anymore from facilitates that a little bit better too.
It can. I think pelvic physical therapy, I still like, we have like 10 plus new patients a week here at our office between all the therapists. And I guarantee you that at least 1 or 2 of them every week says, I had no idea pelvic physical therapy was a thing. So we're getting there where more and more people do know about it, but it's still, not well known about. So it's definitely, and sometimes people are like, yeah, I thought that was for little old ladies who pee their pants, and that's not me. And it's like, well, no, like everyone has a pelvis and everyone has pelvic floor muscles. So everyone can potentially have pelvic issues and that. So yeah, it's getting better, but it's still not there yet.
Yeah.
And if someone needs pelvic floor PT, is there a place where people can find a qualified pelvic floor therapist? And what should they be looking for in a PT?
Yeah. So if you are not local to St. Louis, there are directories that, so our national organization has one. So the APTA's Academy of Pelvic Health has a PT locator that you can put in your zip code and find people who are certified pelvic physical therapists. There's also one, pelvicglobal.com, which goes all over the world. So if you happen to be outside the United States, you might be able to find one that way. So those are some directories that you can do. What I would say is pelvic physical therapy for the last couple of years in social media has been blowing up more, like people are talking about it more. And that's, so there are a lot of people starting to hang out a shingle who say, I do pelvic physical therapy. You want to ask about, what their training is. Like, Dr. Becky Lynn had to go through all this extra training for the Menopause Society and that. And like I went through extra training to become a board certified women's health physical therapist. We typically say pelvic physical therapist now because everyone has a pelvis, not just women. But and we work with men and women at our practice. Some pelvic physical therapists only work with women, so you have to ask if you're a guy. That finding a practice that works with men. Other things to think about is like what part of their caseload is pelvic physical therapy. So many pelvic physical therapists, myself included, my background's in orthopedics. Like I started out doing hips, knees, shoulders, and I still do some of that because it's all interrelated with the core and the pelvis. But if you've got someone who, 75% of their caseload is post-op shoulders and knees, and they like to dabble in pelvic physical therapy because they're kind of interested in it, then you may not have someone who that's their expertise with it because it's one part of many things. And that, so you want to see if the therapist, is it this their passion and what they do all the time, or is this just something, because I help lab assist for some of the coursework for the national organizations, and we've had patients or people, pelvic or physical therapists who show up for the courses who are like, yeah, my hospital system said we need to start a pelvic program and they nominated me, so I'm here. And you're like, oh, you have no interest in being here, but you got nominated to start. It was like, oh, okay. And again, that's not all the situations, but you want to know that's the person, this is what they really want to focus on and do the best at. So.
Well,
Nice.
should we open it up to any questions that anybody may have?
And Brooke, where are the legacy locations? Because you have more than one location, right?
We have two, yeah. So we're at Doherty Ferry and Big Bend Road down. It's the corner of like where Kirkwood and Valley Park and De Pere all come together. And so like about a mile or two west of 270 on Doherty Ferry is our main location. And then we have a satellite location that's up in St. Peter's. That's like at 364 in Jungerman. Didn't realize until I went out that direction how big St. Peter's is. And that they're like, oh, you're on that end of St. Peter's. I was like, what does that mean? Like, I didn't realize that, like,
The Wild West. You just never
yeah,
know
like,
what all's out there.
okay. So, yeah. So, and we're open from 8 to 6 on Monday through Thursday, and then 8 to 5 on Friday. So we have pretty good coverage as far as getting people in, honestly, within the week or so if they need to get in, just depending on their availability, so that people don't have to be waiting to get care.
Fantastic.
When it comes to us referring people to you, are there, and even our colleagues, right? Like as we're spreading the news and talking about this with them, are there certain things that you wish everyone referring to you would tell people or tell you ahead of time?
It's for telling the patient, it is helpful, especially if the person, like when you recommend pelvic physical therapy, their eyes kind of go a little bug-eyed or whatever, and they're like, what? If you can give them a little bit of heads up that, like, just so you know, it might involve an internal evaluation of the vaginal canal, but this is to your comfort level. Like they will talk it through with you and that, but they are really the experts in the musculoskeletal system as it relates to the pelvic area. And so I think there's a musculoskeletal component to this, and we're going to get it figured out. So giving them a little bit of heads up. Women are more used to it because we go to a gynecologist yearly and we're used to that. Guys, they're the ones who, they get a little bug-eyed when that we're the first person telling them what the evaluation might entail. And it's like, oh, it would have been really nice if your urologist had told you that this was going to be part of the evaluation.
Surprise.
Yeah.
Okay.
So.
Got it. Okay. Thank you.
So question in the chat. So about insurance, and does insurance cover pelvic floor PT or out of pocket?
Gotcha. So pelvic physical therapy, if you're trying to decide if your insurance plan covers it, you just need to look at what is your physical therapy benefits. So there are not separate pelvic physical therapy benefits. So if you look at your plan and see, what does my plan cover for physical therapy? Now, the caveat to that in the pelvic physical therapy world is because of the nature of what we do, we work one-on-one with a patient behind a closed treatment door. So in many physical therapy clinics, if you've never been to one, it's super common to have, it's just a wide open gym space. We've got like 20 people there all at one time, and the therapist might have 2, 3, 4 people that they're kind of bouncing between. That does not work in the pelvic world. And we have to be one-on-one with our patients, and we're typically one-on-one with them for about an hour. So because of that, and because of how each year every insurance company starts to reimburse less and less and less, many pelvic physical therapy practices who aren't part of a big hospital system are out of network with private insurances, because we want to continue to partner with the patient to meet their goals and optimize their care the way that they need it to be. And so it depends on the actual practice that you're looking into, whether or not it is, if they're out of network with the insurance. So at our practice, we're out of network with most private insurances. We're in network with Medicare and TRICARE, but we do submit the claim to your insurance company for us. You pay us at the time of visit, we submit the claim, and if you have out of network benefits, your insurance company reimburses you directly. Other companies might be completely what's considered out of pocket, where you pay them, they give you a super bill that if you wanted to, you could try to submit it to your insurance company. And if you have out of network benefits, you may be reimbursed. So each plan is different, but if you're looking at your insurance plan specifically, you don't need to ask about pelvic physical therapy. You just need to ask about physical therapy to see what your physical therapy benefits are.
No.
A great question.
You're welcome.
All right. Was there anything we haven't talked about, Brooke, that you feel like would be important kind of in this area?
I mean, I think we've hit on kind of the major things. I mean, the most common diagnoses that we're seeing, especially in the menopausal age woman here at Legacy, are bladder leakage, urgency and frequency issues, pelvic organ prolapse, like chronic pelvic pain or pain with sex, and then like bowel, like fecal leakage or constipation type issues. And so the pelvic floor muscles work for sphincters on both the front side and the back side. And so oftentimes, again, with the estrogen changes, this is a time of life where women can start to notice a little bit of fecal leakage happening, especially if they had an episiotomy or tearing that went all the way back into the external anal sphincter. Because again, the body compensates for a while, and with estrogen around, everything can be big and fluffed up and supple. And when it goes away, we lose that suppleness and the ability to compensate for like scar tissue that's not doing its job as well just goes away. And that's when people start to notice some issues in that respect. So that's one of the other common areas that we work with that we maybe didn't touch on as much.
I think it's important to know because a lot of people are experiencing those things and really worried about it and really worried about surgery. And so if they can come see you or somebody that like you to have that evaluation, and then working in conjunction with perhaps a urologist or other specialists to maybe minimize surgical intervention, but also support if that is what they really need, then using the physical therapy like post-op to help like make that make those recovery process like much smoother.
Yeah, and one thing that I'll end with it is like if women or people are exploring surgical options, sometimes there is a need for that. Like that prolapse repair or bladder slings or other things can be super, super helpful. It doesn't have to be an either or. Like if I bring back my orthopedic background, like if someone tore their ACL, at this point in time, it's super normal for them to go to physical therapy beforehand to make sure they've got good range of motion in their knee and everything. They have the surgery, and then they go to physical therapy afterwards to rehab everything. And we don't think about sending people to pelvic physical therapy or any type of physical therapy when they have abdominal or pelvic surgeries. And that in my lifetime, I'd love to see that change. Here at Legacy, we've started a community class series. We need to get our next one scheduled, but where we're doing education for women who are going through a hysterectomy, women who are going through prolapse surgery, and men who are going through prostate surgeries to help them. It's meant to be a class that you come to ahead of the surgery, so you learn how to optimize your muscles and body and what you need to do to recover, and then introduce the idea of why you might want to rehab afterwards and not just sit still for the 6 weeks and then just try and go back to your regular activity. So that's something we're trying to normalize here too.
Wow. Well, thank you so much for joining us today. In addition to like that series you mentioned, if people go to your social, to like your Instagram site or Do you have a
Mhm.
Facebook page too? Like, is that where
Yep.
they would learn about any of the other like future
Yep,
seminars?
all of our
stuff like that?
socials, I kept it simple, are all Legacy Therapy STL. We release videos on YouTube every week, and then we are, you know, if you like short form videos, that's Instagram, but yeah, we're on Facebook, and we're even on Pinterest too, because you know, why not? So
Yeah.
so yeah, that's where you can
Well,
find us.
great.
So very cool.
Well, great.
Thank
All right.
you.
Thank you so much.
Thanks
Yeah,
for
thanks for having
coming.
me. It was
Can't wait to
great.
talk again. Take
Yeah.
care, everyone.
Yeah.
Take
Everybody,
care.
bye.
Bye.
Bye.